We've got to wait for them to do the okay. Where am I going to
You can nice watch it from here.
Yeah, but where am I sharing?
Oh.
Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. As I look outside and I see these magnificent blue skies and one or two wispy clouds, I say it's really the place to visit. And I'm hoping that the end of next month, the South African Urogynecological Association, you will be visiting here because we've got a magnificent lineup of urogynecology, and that you can come along, enjoy Cape Town, and especially enjoy Urogynecology Association meeting. My name is Peter de Jong, and it says Professor Stephen Jeffrey, but that's actually him over there. And I'm going to take great pleasure to introduce Dr. Nicole Morse of Lancet Laboratories, and she's going to be speaking on a topic that has changed quite recently. Endometrial Cancer 2023, FIGO guidelines put molecular classification in pole position. Steve, these are the FIGO guidelines from 2023. In fact, next month we have FIGO. In a month's time from today, FIGO finishes. Are you going to FIGO, Steve?
I'm planning.
And at the same time, you're planning to go to FIGO?
Yeah, FIGO in Paris, is it?
In Paris, yeah, that's where it is.
You're going, I know.
Yes, I know. People ask if I'm actually going to see some rugby. And I said, absolutely not. I have no interest in blood sports. Are you also going to the rugby there or not?
No, not at all.
Not at all.
No.
You're taking your wife, eh?
I'm planning.
Planning.
But yeah. And you're taking your wife?
No. She's covering me, you know.
Okay, yeah. It's nice that she can do that. But anyway, I think we should move on to the talk, actually.
The talk?
Yeah.
Okay.
Yeah.
Would you say a few words about Nicole Morse?
No, well, thanks so much to Nicole for agreeing to this. And it was a little bit of a last minute, but thanks so much. And we're really looking forward to this. I think endometrial cancer has always been something that has been a little bit controversial. And, you know, the classifications, etc. So it looks like there's quite a lot of new stuff to know. And we look forward to that. And Nicole's a very good go-to person, you know, when you get an abnormal PAP or an abnormal histology, and she helped me with some of my bladder biopsies as well. So absolutely great to have you with us on this webinar, and you can fire away and start sharing your slides.
Just a quick reminder, next week, ladies and gentlemen, cystoscopy and its importance to the general gynecologist, and that's Alison Moore. This webinar is sponsored by the Pelvic Floor Foundation of South Africa, and next week we have Estella sponsoring us. So without further waste of time, Nicole Morse.
Hi, thanks, and thanks for the invitation to speak. We have been fighting for 40 minutes with IT issues trying to get on Zoom, so I'm now working off a colleague's laptop. So Chris is going to hopefully get me on to share the screen. And I apologize if we have any breakup in signal, because I'm also having to work off my cell phone's internet. So this is going to be fun. Okay, hopefully everyone can now see my screen.
Yeah, we can.
Right, okay, so endometrial cancer has, for the longest time, we have been working off a histopathological classification. And that is what us as pathologists look down the microscope and what we say, this is a high-grade serous carcinoma, or this is an endometrioid carcinoma. And that's how treatment has been based on that. But we've really been in a transition phase for the last probably 4 or 5 years, where there's this background talk of a molecular classification, we're no longer in a transition phase. We're now slam dunk in a molecular classification for endometrial cancer. And you'll hear the word PROMIS used a lot. So PROMIS stands for the Proactive Molecular Risk Classifier for Endometrial Cancer. So if we go all the way back to 1983, Bokum described type 1, I've gone too far, type 1 and type 2 cancer. So type 1s were our endometrioids, and those were graded from 1 to 3. Type 2s were all the others, the serous, the clear cell, the mixed, the undifferentiated, and the carcinosarcomas. Then in 2013, the Tumor Genome Atlas noticed that, or they classified, I think they took 273 endometrial cancers, and they noticed 4 different molecular categories that these tumors fell into. There was a pol mutated group, a mismatch repair mutated group, a no specific molecular profile, and a p53 abnormal. And it's been spoken about for the last, well, since 2013, so that's 10 years now, but nothing much happened until 2020 when the WHO included it in their guidelines. And now, 21 July 2023, the FIGO staging of endometrial cancer has now been dramatically changed by the molecular classification. And there's 2 things that FIGO's done now, is not only have they used a molecular classification, but now histologic types have also come in, and tumor patterns have come into the staging of endometrial cancer. But why did we need a molecular classification for endometrial cancer? And the answer is honestly the grade 3 endometrioids. These are the ones that as pathologists, we're actually very bad at getting right. And there's very poor interobserver variability, even amongst expert pathologists. And it always comes back to grade 3 endometrioids, high grade endometrioids. Even with immunohistochemistry, we are not very good as pathologists at accurately diagnosing this specific tumor. And we've known for a long time about this morphologic sort of ambiguity. And we've also known for a long time that there's been a bit of a molecular overlap, and p53 mutations sort of crop into the endometrioids, but they're not supposed to be there. So what happened in 2013 is the Tumor Genome Atlas took 273 endometrial cancers, and they did, high level molecular testing that is certainly out of my realm of possibilities. And they came up with 3 or 4 groups. And these groups had significant progression-free survival differences. And if you see that top line, the pol mutated group, after 120 months, these patients just did not progress with their disease. Compare that to the red line, which is your p53 mutated group, who had an incredibly poor prognosis. Your mismatch repair and your endometrioid or no specific molecular type, they have an intermediate prognosis. So this is obviously quite startling that there's a group of endometrial cancer patients who can do incredibly well. So let's go into them. So the pol mutated group, pol mutations represent about 10 to 12% of our endometrial cancers. It's across all the histo subtypes. So clear cells can have it, seruses can have it, endometrioids can have it. But it particularly clusters in your high-grade endometrioids. And the importance, like I said, is the excellent prognosis. Your mismatch repair deficient group, now we use the words mismatch repair and microsatellite instability interchangeably. Technically, if you're doing immunohistochemical staining, you call it mismatch repair. So the mismatch repair group is about 40% of endometrial cancers will have this. Again, it's across the different subtypes, so low-grade and high-grade endometrioids, as well as your serous cancers. It's an intermediate prognosis, and a quarter of these patients could have Lynch syndrome, which is its clinical significance. There's also some therapeutic significance to it, I'll touch on later. Your no specific molecular profile, for all intents and purposes, these are your endometrioid tumors. 60% of low-grade endometrioid tumors will have no specific molecular profile, but a percentage of high-grade molecular tumors can also have this, and they have an intermediate prognosis. Then your p53 abnormal category, which is about 18% of endometrial cancers, these are your serous carcinomas. And you would have seen in your reports, if you get a histopathology report of a high-grade serous cancer, the word p53 has been mentioned somewhere in these. And these have an incredibly poor prognosis. Let's just go more into this pol mutated group with their excellent prognosis. So now my animations are not popping up. Hold on, let me try. Pity. Okay, sorry. This POL mutated group has an extremely good prognosis. It usually occurs in younger women and in thinner women, but they are very aggressive looking tumors histologically, and they often have more than 50% myometrial invasion and extensive lymphovascular invasion. But as you can see from the data, they do extremely well. So in order to make a molecular diagnosis more accessible to everyday pathology labs, they came up with the PROMISE classifier. And what the PROMISE classifier says we must do is we must take the endometrial cancer and we need to test for a POL mutation. If there is a pathogenic mutation, you have a POL mutated endometrial cancer. You have an excellent prognosis, and you can possibly have no adjuvant treatment or de-escalate the treatment. This is done through next generation sequencing or Sanger sequencing, which is done in a molecular lab. I'll tell you about that a bit more later. If the POL is wild type, and when you hear the word wild type in molecular setting, it means as in the wild, so normal or non-pathogenic. Then you need to know, is the tumor mismatch repair deficient or mismatch repair proficient? And a mismatch repair deficient tumor has an intermediate prognosis. We diagnose it based on the immunohistochemical expression or loss of expression of your 4 mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. Not only is the prognosis of this group intermediate, but these patients I suspect might benefit from PD-L1 inhibitor, your targeted therapy, and also radiation therapy. Should your mismatch repair pathway be proficient, then P53 comes into play. If you have a wild type or a non-pathogenic P53 gene, you then have a no specific molecular group of tumor. That's an intermediate grade tumor, and standard radiation and hormonal therapy works for these patients. However, if you unfortunately have a P53 mutated tumor, we know this is an extremely poor prognosis, and chemoradiotherapy, maybe some targeted therapy, is used in these patients. So in the actual laboratory, how do I make these decisions? Well, P53 is an immunohistochemical stain. It's a simple look at under the microscope. I look for brown staining in the nuclei, complete overexpression or complete brown. So every nucleus is expressing P53 is mutated, as is complete lack of expression. So P53 is a tumor suppressor gene. It should be working in the background in all your cells to a point, but complete overexpression or complete loss would equate to a mutated protein. Mismatch repair or microsatellite instability, that's 4 immunohistochemical stains we do. This is the loss of nuclear staining that we would then say is a mismatch repair deficient tumor. And then POL is a next generation sequencing. So that needs to go to the molecular lab where they extract the DNA, they sequence it, and then it's quite a big gene. And then within that gene, they look to see if there is a mutation. What does this all mean? Why do we care? Well, data from the PORTEC 1 and 2 trials showed that, as I've said multiple times now, a POL mutated tumor is a favorable prognosis and might be unlikely to benefit from adjuvant treatment, whereas a P53 abnormal tumor has a very strong negative prognostic value, and these patients with a very poor survival are only going to respond to chemo and radiotherapy. PORTEC 3 is ongoing. I think PORTEC 4 is even started now, and that's looking at how this might impact your surgery. For example, if you have a P53 mutated tumor, do you need to do a sentinel? Do you need to do a frozen section for depth of invasion? Because should you not be doing sentinel nodes regardless, because these patients do so poorly? Conversely, if you have a POL mutated tumor, don't bother to do lymph nodes and omentectomies because these patients do so well. That data isn't yet out though. May 2022, the ESMO clinical practice guidelines now recommend complete molecular sequencing for all endometrial carcinomas, regardless of their histologic type. That should be standard practice. So that is a P53 immunostain, 4 mismatch repair immunostains, and POL sequencing. A year later, FIGO has agreed that this is important enough that it should be incorporated into the staging of endometrial cancer. And I'm now going to go into the new FIGO 2023 guidelines. Just to recap, this was 5 years ago. Endometrial cancer was staged surgically. So a grade 1 tumor was confined to the uterus. A stage 1 tumor was confined to the uterus. A stage 2 tumor was into the cervical stroma. Stage 3 is regional spread, and stage 4 is distant metastasis. So the new FIGO guidelines
showing us something that we remember, because a lot of the stuff has been pretty new to us. So your Peter and I are sitting here a little bit at sea with some of this new stuff. So it really is quite a new sort of development in endometrial cancer. So yeah, it's actually going to be very interesting for us today. So I mean, this is the old one, and it's really taken a giant step in a brand new direction. So yeah, that's very interesting.
Completely different dimension,
Yeah.
direction.
It's
dramatic
to this molecular stuff. Yeah. So
yeah, and that's, look, it's due. So these new guidelines, the molecular is very important, but I'll show you now. They still realize there are settings where molecular isn't possible, and that's normally financial reasons. But the new guidelines have also included the histology, and the subtypes have changed the 2023. So this is just to show you where we were. It was very simple, confined to the endometrium, into the cervix, local spread, metastatic spread. Quite a simple staging.
Yeah. Okay.
Now they want to know the histologic type is important, and now we know. Now they want us to use the words non-aggressive, which is your grade 1 and grade 2 endometrioids, versus aggressive histologic types. Notice grade 3 endometrioid has now dropped into the aggressive histologic type. So we no longer talk about type 1 and type 2. We're non-aggressive and aggressive. Grade 3 endometrioid is the category, as I alluded to right in the beginning, that really worries. That's the really worrying group, and the ambiguous group, and the group where we don't get it right pathologically. And so this is prognostically, clinically, and molecularly a very heterogeneous group. And this is the group, the tumor type, that benefits most from applying a molecular classification. Because within grade 3 endometrioids, you are going to have extremely good prognosis groups, the POL mutated ones. You're going to have extremely poor mutated groups, the P53 abnormal ones. And then you're going to have the intermediate groups. Without a molecular classification, high-grade endometrioid carcinomas cannot be appropriately allocated to a risk group. So that was histologic type. Tumor grade is still to a degree important. It's really important mainly, again, in your endometrioid cancers, where now we have a binary system. So now endometrioid carcinomas, where we used to say grade 1 endometrioid, a grade 2 endometrioid, the WHO now wants us to say low grade versus high grade. How we tell that as pathologists, anything with more than a 50% solid growth pattern will be a high grade tumor. Anything less than 50% is going to be a low grade tumor. All the others, the serous carcinomas, the clear cells, the mucinous, the carcinosarcomas, by default, those are high grade tumors. Okay. Myometrial invasion, nothing's changed here. We've always known myometrial invasion is an essential prognostic risk factor in endometrial cancer. And again, it's more than 50% versus less than 50%. There's some pink and purple to keep you entertained from a pathology point of view, and we just measure it from the top of the myometrium towards the serosa, and that's done under a microscope, more than less. Nothing there has changed. This is quite interesting. So lymphovascular space invasion is one of the most important adverse prognostic indicators in endometrial cancer. And in 2015, the PORTEC-1 and the PORTEC-2 trials, they did a pooled analysis, and they said substantial lymphovascular invasion, in contrast to focal or no lymphovascular invasion, is the strongest independent prognostic factor for pelvic regional recurrence, distant metastasis, and overall survival. But the wording they use is odd, because what is substantial versus focal? What is extensive versus focal? So there's a little bit of uncertainty, but the WHO says 5 vessels. So if you have more than 5 vessels with lymphatic or vascular invasion in your endometrial cancer, your prognosis is much poorer than if you have less than 5. I'll show how this has changed the guidelines later. This is one of the biggest things that's changed the staging. The other thing that they talk about now is adnexal involvement. And we see this every couple of months, we get an endometrial cancer, and the same patient has an ovarian mass and ovarian cancer. And what are we dealing with? Are we dealing with synchronous tumors? Are we dealing with metastases? And how the FIGO wants us to now approach it is, if you've got a high-grade endometrioid carcinoma, the ovarian involvement is always a metastasis. However, if you have a low-grade endometrioid carcinoma, the situation's a bit more complex. Now, there has been shown to be a clonal relationship, so that molecularly the endometrial cancer and the ovarian tumor are related, which suggests that one has spread to the other, but the clinical outcomes in these patients doesn't correspond to that. So that clinically, these patients don't act like metastatic disease. And so because of that, there's been a move to say that if you have simultaneous low-grade endometrioid carcinomas of the endometrium and the ovary, these can benefit from conservative management. In other words, they can be treated as two independent primaries, so long as certain criteria are met. The endometrial tumor must have less than 50% invasion. It cannot have substantial lymphovascular invasion, and there cannot be any additional metastases elsewhere. Similarly, the ovarian tumor has to be unilateral. It has to be limited to the ovary, and it can't have breached the capsule. If that is met, you treat these as two independent stage 1 primaries. If any of these criteria are not met, this then becomes an endometrial cancer with mets to the ovary, in other words, a stage 3 tumor. So this is the new 2023 FIGO staging. So stage 1 can be a disease that is limited to the endometrium, which is a non-aggressive histologic type with no lymphovascular invasion. Oh, now I'm losing. Sorry, Chris, I have got a... Sorry, Chris's laptop is playing up. All right. Stage 2, the moment you have cervical invasion or lymphovascular invasion, you're stage 2. Now remember, in 2018, it was just cervical invasion that made you stage 2. Now, if you have substantial lymphovascular invasion, you're also a stage 2. Or if you have an aggressive histologic type, you are now stage 2. So that means if you are a grade 3 endometrioid tumor, even if you're less than 50% myometrial invasion, even if you don't have cervical involvement, you are automatically a stage 2 tumor. Stage 3 hasn't changed, it still remains local regional spread. So that's the
Oh, Nicole, it's Peter here. And we have a question that we hear from Anonymous. Can you just digress? Anonymous he's from Nairobi. He asks about stage 1, confined to the uterine corpus and ovary. Clearly, this is very new because in the past, it was just the uterine corpus.
Correct. Well picked up.
Why would they,
yes.
Yeah, why would they include the ovary under these stages? Because in the olden days...
This previous slide, exactly that I said about. So they are now treating these, so that confined to the ovary, it's got a little hashtag next to it or a thing, because it's obviously got a proviso to that. And that's for this reason, that if it is confined to the uterus corpus and the ovary, and they are both low-grade endometrioid and fulfilling these criteria that I'm showing now, that's still stage 1. Okay.
Got it.
So if it was a high-grade endometrioid and it was in the ovary, that's stage 3.
Okay. So they're going to be pretty...
Okay. So if these criteria are met, you can treat both the ovary and the endometrium as two independent primaries. Right, like I said, it's got a lot more complicated because they've added in all these provisos, but that stage 1 confined to the ovary is only for low grade, limited to the ovary, no capsular spread, no substantial lymphovascular invasion in your myometrium. All right. So that's all. So this is all very much still based on the surgical pathology. This is what your pathologist is going to tell you. They're going to tell you this is a low-grade versus or a non-aggressive versus an aggressive histology. This has got substantial vascular invasion. This has invaded the cervix. where does the molecular classification come into this? Well, FIGO 2023 has now said that complete molecular classification, so that means the pol mutated PCR, the mismatch repair immuno, and the p53 immuno is encouraged because it's going to give us prognostic stratification, and it's going to allow us to plan adjuvant and systemic treatment decisions. The pol mutated group do well, the mismatch repair, no specific molecular profile intermediate. That doesn't alter the stage, but the p53 is a poor prognosis. So in early endometrial cancer, so in stage 1 and stage 2, the presence of a pathogenic pol mutation or a p53 abnormality will now modify the FIGO stage. So in a stage 1 or a stage 2 endometrial cancer, if you have a pol mutation, regardless of how aggressive it looks, so it doesn't matter if it looks like a high-grade serous or a grade 3 endometrioid, it doesn't matter if there is 20 foci of lymphovascular invasion. If you are pol mutated, you're going to downstage that from stage 2 to stage 1. Conversely, if you have a p53 mutated tumor, regardless of if there's less than 50% myometrial invasion, regardless if it hasn't gone into the cervix, regardless if there's no lymphovascular invasion, if you've got a p53 mutation, that's going to be upstaged to be a stage 2 tumor. And that's the new molecular classification affecting the endometrial stage. So all we've done by bringing in a molecular classification is been able to pull a few patients who would have been considered stage 2 out of that and make them stage 1, where you can de-escalate treatment. And unfortunately, there are going to be some patients who were stage 1 who have a p53 mutated tumor who are now going to be considered stage 2. So you can ask, well, that's fine, but why do we need to do pol mutation testing? We give you a p53 immunohistochemical result. We give you the mismatch repair immunohistochemistry and report. It's cheap, it's easy, it's quick, it's standard practice in most laboratories. So you get something called a multiple classifier. So this is if you have a pol mutation, you can still have a p53 mutation. The pol mutation takes precedent. The pol mutation is considered an early pathogenic event. The p53 is considered a late event. And the p53, although it's considered the more aggressive mutation, does not affect the way that tumor behaves. Pol will always take precedent over mismatch repair. Mismatch repair always takes precedent over p53. So multiple classifiers exist, which is why you need to completely classify your tumor. You can't just go on the immuno and say, oh, it's p53, I don't need to worry about pol. Okay, so that is stage 1 and 2 in advanced endometrial cancer. So in stage 3 and stage 4, the stage is not altered by any molecular classification. Yes, it can give you prognostic information and treatment directions, knowing what the molecular classification is, but stage 3 and stage 4 remain a surgical classification. Advanced stage pol endometrial cancer, so an endometrial cancer with a pol mutation that's metastasized all over the peritoneum, is very, very rare. The clinical behavior seems favorable, but we don't have enough evidence yet to say how these should be, that these can be managed more conservatively, so they're still treated as stage 3 or 4, depending on where they are. So this is all great. And I mean, this sounds wonderful. We can now tell which patients are going to do well, which patients are going to do badly. We can guide treatment decisions. But I mean, the elephant in the room is unfortunately availability to testing and costing. And while the assessment of mismatch repair and p53 via immunohistochemistry is widely available, cost and access to pol testing is a barrier, and we do realize that is not accessible to everyone. We have been doing pol mutation testing for a year now. We have validated it is working extremely well. We do it as part of a panel. So if you order a pol mutation test on one of the endometrial cancers you sent me, we send it to our molecular lab, and they're going to target 30 different DNA and RNA targets. And there are some genes in here that the oncologists get quite excited about, like the NTRAX, and there are other mutations that benefit them. But within this test is our POL mutation. This can be done on formalin, well, it is done on the formalin fixed paraffin invariant tissue. It can be done on the curettings, or it can be done on the hysterectomy sample. The limitation is the cost. This test is approximately 14,000 Rand. Medical aids do pay for it. So acknowledging that not everyone can do this and not everyone can afford this, the British Association of Gynaepathologists and the British Gynae Cancer Society came up with what I think are quite good guidelines onto how you should approach your endometrial cancers. So their guidance, and I think in private practice this is quite a useful way that we can apply it, is on every single endometrial biopsy, you could do we do the mismatch repair immunohistochemistry, a p53 immunohistochemistry, and an estrogen stain. If those come back with a mismatch repair mutation or a p53 mutation, you're then obliged to go and do POL mutation testing because, like I said, multiple classifiers, POL would still take preference over p53 or mismatch repair. If those all come back normal, then you wait for your hysterectomy specimen. And then we look at the final histologic type, the final grade if it's an endometrioid, the final stage, and the presence or absence of substantial lymphovascular invasion. And if you have a low grade or a non-aggressive endometrioid carcinoma that is less than 50% myometrial invasion, no focal lymphovascular invasion, that's estrogen receptor positive, these are going to be your no-specific molecular type group. These are low-grade endometrioid tumors. They're not going to benefit from POL testing, and your management's not going to change in these. You're not going to give any adjuvant escalated treatment. However, should you have a stage 1 or 2 non-endometrioid or grade 3 endometrioid, so in other words, an aggressive histologic type, even if there's not substantial lymphovascular invasion, or if you've got an endometrioid tumor that is ER negative with substantial lymphovascular invasion, then you're going to want POL testing, because if you're POL mutated, these are no longer going to be stage 2, these can be downgraded to stage 1. However, if after the surgery you've come back and there are local, regional, widespread metastases, you're not going to worry to do POL testing in these patients because they are going to require escalated treatment and they've already spread beyond where POL usually goes. So where are we going with this? There's currently 4 international clinical trials under the Overreaching Rainbow program that are looking at sort of refining this further, seeing, like I mentioned earlier, if we know in your endometrial curetting that a tumor is p53 mutated, do we need to bother with frozen sections, or should you not just be going ahead and doing lymph node dissections and omentectomies? If we know on the biopsy that this is a POL mutated tumor, don't worry with having a frozen section and doing anything further. You know your patient's going to do really well. That data isn't yet out, and the FIGO guidelines do encourage the collecting of your molecular subtypes regardless of stage so that we can keep updating our knowledge on this. PROMISE 2, so this is a one-step molecular classifier. This is more from a laboratory side. They're currently looking at, rather than doing mismatch repair immunohistochemistry and p53 immunohistochemistry, can we not just test the MSI and the p53 in the molecular panel we do with POL? And if you look at the panel we give you, in here is p53 and microsatellite instability. So in the molecular result, you will actually get that data anyway. At the moment, though, immunohistochemistry is relatively cheap. It's quick, it's easy, and the guidelines haven't changed from the original PROMISE classifier. So what this all means is that the FIGO staging of endometrial cancer does look more complex. However, we've separated out a group of patients who are going to do really badly. We've separated out a group of patients who are going to do really well. And this should help with more refined treatment and future collection of outcome and survival data in women with endometrial cancer. And I really hope that was in any way understandable. And thank you for listening.
Thank you. Thank you so much, Dr. Morse, for that most illuminating and talk. And as Steve said, it's made a huge difference to our understanding. I still grew up in the time of Professor Tiltman. Do you remember Professor Andy Tiltman?
No.
Before your time. And he used to say that, do you remember him, Nicole Morse? Professor Andy Tiltman?
No,
For your
I don't.
Anyway, I used to say that your histology report depends on what you had for breakfast. But I can see now we've moved away from breakfast classification. And with this new move in towards myometrial invasion and molecular classification, I can see why, in fact, you pay 14,000 Rand for your histology, because it makes a huge prognostic difference to get the right treatment with the right adjuvation for the right woman. And I'm going to ask Steve if he has any questions to start with.
So, so just from a practical level, obviously, what gets tested reflexly in Lancet now? I do hysteroscopy next week. I do some curetics. I send it off to you guys. Where do you guys start with that one, and what gets tested sort of as a baseline in those samples?
Yeah, good question. So we obviously, the specimen gets processed, H&E slides arrive on our desk. We make the diagnosis of a endometrial cancer, and then we do almost a standard panel of immunohistochemical stains. So P53 is routine, estrogen receptor is routine, and mismatch repair is routine. So those are right up front. Then you might have noticed, if you've had any reports, we sign it out, and then there's a comment saying, please contact the laboratory if pole sequencing is recommended. Then I suppose the advantage of doing pole in the biopsy is the turnaround time for the next gen sequencing is 10 to 14 working days. So by the time you have gone to surgery, had your hysterectomy, your pole results are out, and the oncologist will know better what to do with you. But you can obviously wait for the hysterectomy specimen, and then we will do the pole on that. That, from what I've seen so far, the requests I've had personally for pole, it's all been on the hysterectomy specimen. But as you can see from the British guidelines, they suggest doing it on the biopsy. Oh, no, sorry, they recommend on the biopsy, like I've said, the mismatch repair, the P53, the ER, all cases. Then you wait for the surgery, and then you do the pole testing.
Thanks, Nicole. Another question over here from Habib M. Habib. He says, how much tissue is required? Because if you take a tiny hysteroscopy specimen, the biopsy volume is extremely limited. Is that sufficient to make these diagnoses, or do you need curetic?
Yes, they are. You know, for us to make a diagnosis of endometrial cancer, there actually has to be a fair amount of tissue. Remember, especially your endometrioids, we're just looking at glands, and we need a certain volume to be able to say, yes, these are crowded within minimal stroma, therefore this is a grade 1 or a low-grade endometrioid. So just by virtue of the fact that as a pathologist, we've made the diagnosis of endometrial cancer, almost defaults to saying there'll be enough in your curating specimen. This next-gen sequencing has got really refined, and so long as the tumor is viable, necrotic tissue won't work. But, you know, if it gets to the lab, they extract DNA and they look for certain markers, and if there isn't enough, they say we can't do the test, and medical aid doesn't get charged. So it's always worth trying. I have never, so far, I haven't had an endometrial tumor fail because of a lack of tissue.
Okay. Yeah. Steve, one more question over here that's come up, I see. These are all malignancies. What do we do, asks the questioner, if there are simple or complex or hyperplasia? What about those groups of classifications of histology? Do they still exist, or has that been refined as well?
Yeah, that's a whole other talk. That's a good question. So endometrial hyperplasia, we're still stuck in the terminology of simple hyperplasia versus atypical complex hyperplasia. Are we? And I don't know why we can't let it go, because we're actually not meant to talk about atypical complex hyperplasia. We're meant to talk about endometrial intraepithelial neoplasia. And endometrial intraepithelial neoplasia is sort of like cervical intraepithelial neoplasia. We know that is on a dysplastic malignant sequence, whereas, so we diagnose it slightly different. EIN, we have different criteria for diagnosing down the microscope to atypical complex hyperplasia. atypical complex hyperplasia doesn't necessarily mean it's a precursor to cancer, but EIN is. And I wish we would stop talking about, and we're bad because as pathologists, I do it all the time. I call atypical complex hyperplasia. We shouldn't. If I tell you EIN or endometrial intraepithelial neoplasia, that's a patient who's going to need a hysterectomy because she's got a pre-malignant condition with a fairly high chance of having coexistent endometrioid cancer in that sample, just wasn't picked up on the papil.
Okay, so we can't treat those ones, the EINs with the Mirena, but the other ones we can. Is that what you're saying?
Exactly. So exactly. So what we've done with EIN, and that's a WHO criteria, how we diagnose it, that's a actual pre-malignant thing versus the atypical complex hyperplasia, where some of them really aren't at all, and a much lower rates of coexistent endometrial cancer. Simple hyperplasia we know is not pre-malignant, and that can be treated with hormone therapy.
Okay.
Sure. It's interesting. Has any of this helped us to, because I mean, I think one of the big issues is, you know, when you want to, you get a malignant, you know, endometrial sample now, you know, the patient needs a hysterectomy. One of the big issues is who does it, and, you know, where does the lymphadenectomy fit into the whole thing? Has some of this helped us to work out? I mean, obviously, if there's a poll, sort of.
Yeah, so that we're waiting for that data. So that's an excellent question, and that I was asked to talk about that at the gynae conference a couple of years ago. So we don't have the data yet to say. So what's happened with the FIGO staging now changing is the oncologist's management is now different, right? Because now we're saying you're stage 1 versus stage 2. The oncologists now need to know pole testing. From the surgeon's point of view, we don't have the data to say that a pole tumor means you can de-escalate your surgery. We're waiting for that. PORTEC 3 and I think it's even PORTEC 4 are supposed to give us that information, and that'll be great if it does. And you know, because you're going to be able to save theatre time by not having to wait for us to cut open the uterus and look at depth of invasion and look for all of this. You're going to be able to, and you're also going to be able to say to the P53 mutated patients, look, you're having your lymph nodes out up front. Doesn't matter. You've got an aggressive tumor. But as of yet, the guidelines don't say change or surgical management for this. This is staging and oncological management that's changed.
Okay. Thanks. That's nice. We look forward to that data, and I think it'll help from a practical level a lot. Leon Nell's got a question. Could you do these tests on an endometrial brush sample with relative accuracy, like doing a pap smear?
What's a brush?
Yeah, sure. Quite possibly. I haven't. We can do this like next gen panels on minute samples. I mean, I can do it I do them quite often on pancreatic fine needle aspirate samples. So yes, I don't see a reason why not. The problem would be you haven't had the ability for a pathologist really to look at it and assess how much tumor there is. Technically, I don't see a problem. I would still say a curating sample and that we look at and do an H&E on first is probably better, because also that will tell you a little bit more information. It's going to give you the subtype. It's going to confirm it's cancer.
Excellent. Yeah, well, I mean, Nicole, thanks. This has really opened up a whole new world of endometrial cancer to those of us who are still stuck in some of the old registrar on endometrial cancer. I mean,
it's a complex topic, but the way I've just thought of it is stage 2 tumors are now the aggressive tumors, and stage 1 are the non-aggressive, and aggressive features means aggressive subtypes, P53 mutations, and lymphovascular invasion. That's what's changed. Those are the three.
That's your take-home message, Nicole.
Yeah,
no,
that's my take-home message.
Wonderful. We've had a lot of people on. We've had more than 100, and it's been really excellent. So thanks so much.
Pleasure.
Yeah, the last thing is, apart from reiterating what Steve has reiterated, I'd just like to say that we would love to see you all here next week. And next week is, in fact, Dr. Alison Moore, as I said, cystoscopy, and it's important to the general gynecologist. I hope Nicole is with us for that as well. And I'd like to thank Astellas for next week's sponsorship. So, ladies and gentlemen, it's been absolutely wonderful having you on this splendid Cape Town afternoon. Be remiss of me not to thank the Pelvic Floor Foundation of South Africa for sponsorship, And of course, as always, the use of Steve's minibar. Thank you, Steve.
As always.
And we look forward to seeing you. Remember, in the end of October is the South African Urogynecological Association annual Congress, and of course also those of you that are going to FIGO, which in exactly a month from now will have ended. I hope you have a wonderful time. Thank you very
so
much.
Yeah, thank you. Okay. Bye-bye.